and welcome to Billing Insights, your favorite podcast for medical billing. I'm Taylor,
And I'm Anita.
and we're your co hosts. We are still festive. It is still Christmas time. Merry Christmas.
Happy New Year.
So, today we are going to be going over what is medical billing.
So, medical billing is the process where providers submit healthcare claims to insurance companies for the services that they have provided to the patient.
Providers are doctors.
Oh, yes, providers are the doctors
A lot of
or
people don't know that word.
so physicians, nurse practitioners, physical therapists, any provider who provides a service and wants to get paid for their services from an insurance would submit that claim to the insurance electronically or on paper, or sometimes you can even go onto portals and submit claims that way. It's actually preferred if you submit them through a clearinghouse because it's much faster, but you could technically still submit claims on paper.
Yeah, so the reason that a clearinghouse is faster is say the doctor sees 50 patients in a day. And then if you're going to choose the route where you submit the claims on the portal, you have to type everything in. You have to go to that insurance's specific website and type everything in by hand and then submit. Now, you will get faster payment when you're submitting directly to the portal, or at least I think so.
Mhm.
But if you were to enter all of the charges into one practice management system, you can then send them all out through a clearinghouse at the same time using the claim payer ID, and the clearinghouse routes it to all of the different insurances. So you're only having to go onto one website instead of, oh, this patient has Aetna, let me go to Availity. This patient has United Healthcare, let me go to United Healthcare's website. So it's a lot easier to track, and it's a lot easier and faster to enter if you do it all in the one place and submit it through a clearinghouse.
Right. The clearinghouse is the middleman, kind of between the provider's practice management system and the insurance's portals.
Right. And then the worst option is paper, because then you're
Oh
sending it
no.
via snail mail.
It could get lost. It
And
could,
most of the time, the insurance says no claim on file.
right. And that's a terrible option whenever you're trying to submit claims and it drags out payment even longer from, a typical for Medicare, for instance, you can get payment within 14 days. If you submit it electronically through a clearinghouse, but for paper, it can be 60 to 90 days or longer if they lose your paperwork. So,
Right. And then there are some insurances, like Texas Medicaid,
mhm.
that whenever you're sending your claims via paper, they have this long list of rules. You're not allowed to fold the claim, staple the claim, use red ink. There's a whole list, which we have somewhere, but that can also be discussed in a later class if you guys want to see that. So that is what medical billing is. Let's talk about the revenue cycle management process.
So revenue cycle management is multi steps that you have to go through to keep the provider functioning. So, the submission of the claim and the whole cycle of submitting that claim. So, what happens after you submit your claim to your insurance? What happens before you have to submit your claim to the insurance? All the way through what if your claim gets denied? What do we do then? So, again, it's the process of that whole cycle of submitting that claim, getting it paid, making sure that it's paid correctly, and then submitting the statement to the patient if they have a responsibility left.
So let's go all the way back to the very beginning. The patient is walking into the office. They're about to start the registration process. If you don't do this properly, it will result in denied claims.
Absolutely.
You need to make sure that you, one, have the patient fill out all of the demographic information, their name,
Mhm.
their address, date of birth, social security, phone number in case there's an
Mhm.
issue and you need to call them later. And you also need to scan a copy of the front and the back of the patient's card. If you're
That is
missing the back,
very important. On the back is the address of where the claims get submitted, which even if you're submitting electronically is still important to know.
right, and it also has the claims payer ID most of
Mhm.
the time, which is how we submit it electronically. And there are different places that you can go to try and search for the claim submitter ID or claim payer ID. But the issue is you can search by name. If you type Cigna into that website, then it's just going to pull 500 different Cignas that you're going to have to go through and hope that you're sending it to the right one. And that's not the correct way to do things. So scan the front and the back of the card. So there is some paperwork that you want the patient to sign as well.
So the first thing that you'll need for sure to make them sign, or not make them, have them sign, is what's called the financial paperwork packet. And that just gives a list of statements that say, I understand that if my insurance does not pay for this XYZ procedure, that I am responsible for the remainder of the bill. I'm also responsible for any co-pays, co-insurance, and deductibles if those are assessed by the insurance.
And then there are ABNs or advanced beneficiary notices as well.
That might be required if your patient has Medicare and you think that it's a possibility that Medicare may not pay for this procedure. Now, there are things like frequency or things that are not covered for various reasons because maybe they don't have a diagnosis code that's listed on the LCD that Medicare has. So you would have them sign that so that you can still request payment from the patient and that they sign not only that they're aware that this may be denied, but also that they're aware of how much they are responsible for. So,
And then there is the HIPAA paperwork or the Health Insurance Portability and Accountability Act paperwork. What exactly does that entail?
it's privacy information saying that they're aware of what the privacy policies are. And, it's generally a multi-page thing. So you can also have it posted in your lobby for the patients to view as well.
All right. So that kind of starts the claim submission process. Patient has to sign all of those things, and you need to get all of their information and the front and back of the
Of the
insurance
card.
card.
We always you always wonder why they tell the patient to arrive 15 minutes early to their appointment. It's because they know they have to fill out all this paperwork.
Right. And then you want to, still part of the registration process, after you get the copy of their card, check and make sure that they actually have active eligibility with their insurance and that their benefits are covering the services that you're
hmm
providing. Um, and then that says patient appointment. What
Check
else?
them in. It's
Check
the
them in.
process. So if you have a practice management software, which these days everyone should, but there's a status button inside your practice management software that says the patient has arrived, they're here, so that the nursing staff knows to go out and bring the patient back into the procedure room.
Great. So then we get to the point where the patient is seen. Oh, they need to collect their copay and deductible and
hmm
stuff.
You've already missed out if you've forgotten to collect their copay and coinsurance at the deductible. But it is important to collect that upfront while the patient's at the window because if you don't, you have a less of a chance for the patient to remember or want to pay after the procedure is over. So,
Right. And since the copay is a fixed amount, it's always the same. It should say it on the patient's card as well. Or a lot of insurance cards do have that information. A
mhm.
lot of them don't have a lot of information at all. But since it's a fixed amount, you just collect that every time. Now it's different. It'd always be the same for an office visit, but for a well visit, a lot of insurances cover that 100%. So then
Mhm.
they don't have a copay. So you want to know what kind of appointment that they have and then collect that flat rate. Otherwise, you're missing out on a lot of money. And then
Yes.
you're spending more money to send to them statements and you're spending staff time placing phone calls and things like
Mhm.
that. So, once you've done all of that, the patient gets seen by the doctor. The doctor provides excellent service. The patient leaves the clinic or the hospital, the building. um, and then we get into claim submission. So, first, um, 9 times out of 10, the doctor is doing their own coding, I would say.
For the most part. I mean, some of the providers have a coding staff on staff to do the coding for them, but a lot of providers who are in their own practice doing their own thing will fill out a super bill or something like that.
And
So,
there's a lot of EHRs that have templates for your notes, and
mhm,
then when you select a certain note template type, it
it
automatically
tells
like
you.
pulls.
Hmm.
There are things called macros where like if you type in one little thing, it'll pull all four of these codes if you provide the same services a lot. Like if it's flu season and you're having a lot of office visits and you want to have a macro that pulls an office visit and the flu tests
Hmm. At the
and
same time.
at the same time, then you could just type in your couple of letters and then it auto pulls all of that stuff for you, which speeds up the process.
Just
Um,
make sure that everything that was on that list was actually done if you're going to use a macro.
right. Make sure you sign your note. If you don't sign your note, an insurance request for medical records are going to deny.
Yes.
So then we get to charge entry. So either you have a biller in-house or you have a billing company doing your billing. You give the super bill information to them. They enter the charges into the system, into the practice management side, or if you have an API connection, it might automatically
Hmm.
pull from the EHR side. But charges get entered into the system. And hopefully your biller is also verifying eligibility before submitting
We
claims.
would recommend a double check system for sure.
You verify that the insurance is entered incorrectly and make sure it's getting sent to the right
Hmm.
Aetna if you have 5 Aetnas in your system. And then you submit the claim. In our system, we just hit approve.
Hmm.
And then
So
when
we
you
have a
run into
supervisor,
pay,
right, who double checks it after it's entered by the billing entry staff. But one thing I do want to throw in there is for providers, please, please, please try to keep your locking and signing of your notes in a timely manner because if
right.
you wait 2 months to lock your notes and submit claims, not only does it slow down the billing process, but there's a lot more risk of errors.
And you delay payment.
Absolutely.
If you just enter your stuff every day before you leave, you're going to always have a steady cash inflow.
Hmm.
If you wait an entire month without submitting charges, well, you might be getting a little bit of cash coming in because of AR that's being worked, old claims, or if your office is actually collecting the copays at the front, but the $20 copay from one patient
Doesn't make up for it.
doesn't make up for you not having submitted any of your claims for the entire month. Which, if you have that process and it's always the first of the month, all of last month's charges are in. And if you had a process in place where they steadily submitted it out each day, then you're going to have a regular cash inflow. But all of that's just way too complicated and
Hmm.
unnecessary.
Very unnecessary. And just from our standpoint, just as a billing company, any charges that are submitted to us are submitted to the insurance within 24 hours. And it's best to keep that within 24-hour time frame. Everything then is going out, it's flowing, the money's flowing in for payments at a regular, steady rate.
Right. So then we also get into timely filing. If you are one of the providers who wants to wait a month or two or however long, you risk having a lot of insurances deny for timely if there were any issues in that
Hmm.
process. Say the biller submitted a claim, but then it got rejected and not accepted into adjudication. Then they have to figure out what the problem was. Did the patient actually have that a different insurance with the same ID because they were actually a price impasse or
Hmm.
something weird like that? Or, I mean, what are other
Medicare, I
rejection
was going to say
reasons?
Medicare with their IDs has been hacked recently, and they've been changing a lot of the patients' IDs. The patients don't know that they're going to get a new ID in the mail. They just know they have Medicare.
Right.
And so they don't tell their provider, hey, I have a new ID number. But when you try to submit the claim with the old Medicare ID and it rejects because it's no longer the correct number, then you have to spend time to look up the new numbers. So,
Yes, so there are many different reasons that a claim may get rejected, which can also slow down the submission and payment obtaining process. So after claims get submitted, we get onto claim management. So preferably 98% or higher of your claims are all clean claims and just
Mhm.
get payment. So the claims management half for those claims would just be posting the payment. Really simple. Um, then there are all of the ones that deny. Take it away.
So when you have a denial, it could be for hundreds of reasons. Sometimes the insurance just asks for notes. They want to double check what the provider entered matches what was submitted on the claim. Sometimes there's a mismatch between the ICD-10 code and the CPT code. Maybe you're seeing a patient for weight management, and the requirement by the insurance is that they not only are overweight, but they also have to have high blood pressure or something like that in order to be covered. So, in order to do that, they're going to look at your notes and make sure that those ICD-10s match what was submitted on the claim. And you cannot just put on a diagnosis code to say, hey, this patient has XYZ problem if they don't really have that problem. So, it's very important to make sure that what the provider puts in the notes matches what's submitted on the claim. So,
So, when you receive your explanation of payment from the insurance, if the payment is $0, there will be reason codes and remark codes on there
mhm.
that tell you why the claim denied. Um, a remark code might be M76 after denying CO16. What's CO16? Is that right?
Just needs more information.
Yes.
That's
So
just a
then
generic.
M76 would be invalid diagnosis code. So then you can go and you can take all of your diagnosis codes and see if they have any excludes relationships, things like that. See if there's an LCD for that specific CPT code.
Mhm.
Um, where was I going with this?
Denial reasons and things to watch for.
I mean, so that's how you figure it out. And then you have to go look up insurance policies or call the insurance, or now you can do live chats, which I would
I
recommend
love that.
because then you don't have to wait on hold forever. I've actually found that whenever you call and you're waiting for a rep on the phone, you can get a rep in a couple of minutes just using the live chat.
It's true.
Mm.
And
I
they
feel
will
like
tell
all
you
the
the
phone
same
people are
information. Yeah.
on the live chat instead of on the phone.
It seems to be shifting more that way. Yes.
Yes. So then we also have the issue of outstanding balances for the patients.
hmm
So you start sending statements. You should definitely build a policy with whoever your biller is, and after 3 statements or after 5 statements are
hmm
sent, then you would review them for collections. Maybe send them a final notice, or not maybe, just definitely send them a final
hmm
notice. Try reaching out to their phone number if you can. Place a courtesy call letting them know that they're eligible for collections if they don't make some sort of payment or payment
hmm
plan. Um, and then they would get sent to collections if they did not attempt to make a
Any sort
payment
of payment
on the
arrangement.
bill.
Now, a lot of providers have a set amount for what they want the patient to make a payment on. And typically, our providers will set at least a time frame to say we want this paid off within 12 months. So if they have $100 bill, then the lowest that they could pay would be, what would that be? $8 a month to get it paid off within 12 months, I think. I'm
Is it
not good
eight?
with the numbers. So,
I mean,
anyways, so to get
just
it paid off within 12 months. One thing I did want to mention too, if we have a claim that denies inaccurately, so we would talked about claims that deny for a reason that you have to fix, but let's say that there's a claim that says the patient's not in the right age range for a well visit.
hmm.
And you say, yes, they are. They're 32, and I put the right CPT code down for that age range. Then you have to do what's called an appeal. So, an appeal is it can be submitted online to some portals like United Healthcare. Most of the time, though, at least at this point, appeals have to be submitted on paper. So you fill out the form, and we'll actually have more information on this at a different class. But you fill out the form that they require you to fill out for the appeal, and you give information that says why you think you are right and the claim should be paid when they denied it. So,
And then there's also reconsiderations.
mhm, for some
What's
insurances.
the difference there?
So it's almost like, hey, just take a quick second look at this. A reconsideration, we see that a lot with Medicare, where it's still it's kind of like a half of an appeal, where we can do it online on the portal, we can have them look at it, and again, ask them to take a second look at the claim.
And Medicare also has clerical reopenings.
Clerical reopenings are when you realize that you made a mistake and possibly you didn't submit enough units for your procedure or some other thing like
Maybe you typed 2023 instead of 2024 for the date of service.
something simple. And there are a list of things that you're able to change. So if it's something that's not on that list, you can't change it. But
I don't know if
for the,
year's on the list.
yeah. So again, it's simple clerical issues that you can change, and you just do a clerical reopening. So that can be done on the portal. It can also, at least as of now, can still be done via phone call to Medicare, and the clerks there will help you do the reopening.
So that's kind of the quick version of what is medical billing. Did you have anything else that you wanted to touch on?
I don't think so as far as medical billing, but I did want to go over the books that you would be required to use to learn. And the first one that we have here is, I hope you can see this. This is called a CPT.
CPT book for 2025. That is the current procedural terminology.
Yes. And so inside this book, there's a lot of information. The first page actually goes over places of service.
Well, even before that, you have the front
Oh,
cover, which
yes.
has all of the modifiers, what the different symbols mean in the book, and it
We,
actually has some HCPCS modifiers as well,
mhm.
which we'll go over HCPCS in a minute.
In a different podcast, yes, more
Well,
in depth.
we'll
This
go
is,
in depth, but we will touch on HCPCS in a
yes,
minute.
yes. So it also has places of service. And the really nice thing that I think is really helpful is that it has diagrams. So if you're looking here and you need to know about burns on a patient and you're submitting claims for skincare or something like that, it will actually give you the diagram and pictures to show you what specific body part you're looking at.
Did we want to show
Sure.
them? Okay, so it gives diagrams. And then the other really nice part, I don't know if you can really see this, but it color codes and it
Mhm.
puts everything in a specific order. So evaluation and management codes are always in the front. And then is that anesthesia maybe? It's blue, yeah. Anesthesia. And then you've got integumentary, so on and so forth. But let me see if I can, because I was just thinking of the tabs, you know?
Mhm.
Um, one moment. So you can put all of these little tabs they give you in the very front of the book, and it has the little labels so you can see. I might have been talking away from the mic, excuse me. You can see surgery, integumentary, musculoskeletal, and then you can even label your own little tabs because they have pages for notes. And then you can put all of the different laws, different types of insurances in these little note sections if you would like. And then they
We
have
do recommend that because it makes it easy to find things whenever you're trying to flip through and do different things for coding. So,
right, and then you have like the appendixes at the back that are pretty helpful as well. Some of them are very specific, like one goes over modifier 51.
mhm. The nice thing too is there is an index that will help you find your codes quicker. And again, we will be going over this on a different podcast. So, the next one we're going to look at is our ICD-10 book. And we do recommend that you keep these up to date with the year that you're in because things change every single year. Several hundred claim or CPT codes and diagnosis codes change every year. New things are being added, old things are being deleted. It's important to keep up and keep current.
And
So
ICD-10 is the International Classification of Diseases 10th revision. I'm pretty sure in Europe they're past
10,
ICD-10,
I'm
but
sure they are.
here in the US we are using ICD-10. ICD-9 got kicked to the curb in like
2015.
2015 or
Mhm.
something.
So the nice thing about this, yes, it is very detailed, is very in depth, but it does give a code to every single possible diagnosis that might be out there. And there are some codes, though, if you can't find it, there's a kind of a catch-all code that might be other diseases of the musculoskeletal system. But there will be synonyms.
Struck by a turtle is a very specific one.
So, again, it's just a list of all the diagnosis codes that are possible. And there's chapters at the beginning of each thing that kind of goes over which diagnosis codes cannot be billed together, which diagnosis codes need extra codes added to them. There's all kinds of helpful tips and tricks that would help you be able to code correctly. So, again, this is a very, very, very brief overview of what we're looking at, but we wanted you to know what books that you would need to be able to bill it correctly.
If you'd like to hear more about these books in detail, please sign up for one of our courses at gmslearningacademy.com. That is G as in golf, M as in Mike, S as in Sierra, learningacademy.com.
So, next one we have here is our HCPCS book.
Right. That is the Healthcare Common Procedural System.
Now, these codes start with a letter, whereas the CPT codes start with, or actually are all numbers. But the
Well,
letters,
not that. Is it category 2 or 3? The temporary
yeah,
ones.
well, mostly. Anyways, these start with letters, and the really important part is that they have a table of drugs.
Right. So all of your J codes, anytime that you are administering a drug,
Medication.
medication, where are we going with this? Table of drugs. I mean, you have to find out the unit of measure.
Hmm.
Well, first of all, you also have to have the NDC. So like once a year, whenever it's like flu season, we message all of our clients and we're like, "Hey,
What's
it's
the
flu
new one?
season. What's your new flu vaccine?"
So, medications like steroids and things like that, every time you change manufacturers or every time the manufacturer comes up with a new lot number or something like that, so those numbers, NDC numbers, do change. So, you need to have that new updated information every time something changes. So, just make sure that you're giving that information to your billing people or billing people that you're getting it from your providers or your nurses or whomever keeps track of all of that because it does change and changes a lot sometimes.
And then on the claim form, they're going to want you to match and have your units match your NDC quantity. And so you need to look into these, look at the
Mhm.
table of drugs, find your unit of measure, and figure it out.
And we will be going over this in a different class as well. So,
Right.
so again, a lot of the HCPCS information is used a lot by Medicare, some of it by Blue Cross. Other services might be used in here as well. But you will find some things, especially with Medicare, where you have a CPT code that's used for commercial carriers, and then the same exact thing is used with a HCPCS by Medicare. So make sure that you understand what your carriers want whenever you're submitting your claims. So that is HCPCS. So talk about CDT.
So that is current dental terminology. Those are just another one of the adopted code sets that you use for billing anything dental.
And we don't at this time, bill for any dentist, but all of the dental codes start with a D, so they're easy to recognize.
And then we also have place of service as one of the adopted code sets. You'll see that labeled POS a lot. The most common one that most people would be visiting, like if you go to an office, place of service 11 for
Mm-hmm.
office, 21 is inpatient, 22 is outpatient, 13 is assisted living,
24 is an ASC.
31 and 32 are nursing facility and skilled
Mhm.
nursing. Couldn't tell you which is which, but when I see it, I know it.
And that's okay. So, keeping those places of service correct, insurances make their payment, which could be completely different from an office to an ASC to a hospital, based on where that patient was located at the time of service. And so, even telehealth could potentially, depending upon your payer, have a different payment rate than what you would normally have in an office. So make sure those places of service are billed out correctly.
Yep, or you could get a lot of rejections for that as well whenever you don't have place of service O2, but you're using a modifier 95. United Healthcare is sending that back.
Causes problems. So, as you can see, a lot of different information goes into the revenue cycle process, all of which any little tiny error can cause a denial. So we have to be careful that things are being submitted correctly in the correct order, modifiers are done correctly, your charges are submitted correctly, as far as your fee schedule. If you bill something out at too low of a price, the insurance isn't obligated to pay you the actual amount that they're supposed to pay you. So let's say that you have a office visit that you submitted at $50 and it was supposed to be submitted at $150. And the insurance normally pays you $95 for this office visit. They're only going to pay you $50 because that's what you submitted. They submit it based on the lesser of the charges. And yes, I know that doesn't seem fair, but insurances don't care. So we just need to make sure that everything is set up correctly, make sure that all of your fee schedules and everything in your practice management system are set up correctly so that they pull correctly.
And you're never going to remember every single code in every single
Right.
one of those books, especially the ICD 10. So don't feel that kind of pressure or like don't get so overwhelmed about it.
Mhm.
And if you do go to get certified as a professional biller, you are able to take all three of those books that we just showed you
Yes,
with you,
open book test.
and you're allowed to write your notes in the book too. So again, all of your laws, all of your different types of insurances could be on the notes tab. You just can't have any loose leaf paper hanging out
Mhm.
of it. They'll shake your book and check. But
Right.
if you've written it on the notes page, that's fine. So I believe that concludes our intro to what is medical billing. Again, if you would like to learn more about any of what we just talked about, or if you just want to see our beautiful faces again, you
Aw.
can go to gmslearningacademy.com. Thank you so much for watching. We are really happy to have you here joining us. We really appreciate your support. Don't forget to like, comment, and subscribe since we are new. We really do need that interaction.
We do.
Thank you so much, and
Thank
we'll
you.
see you in the next video.
Bye.
Bye.